quantum computing fundamentally is the best way to process information based on the laws of physics as we know them.
I had constructed what I thought of as the generalization of the universal Turing machine.
Can an astonishingly powerful new realm of computation be found within the quantum world? Will researchers ever realize the goal of what they call quantum supremacy? And what would it mean for our society if they did? From its fundamental building blocks to the ultimate goal of a truly universal quantum computer. Join me, Oxford Professor of Philosophy Peter Millikan, as I explore this and many other questions on the Future Makers podcast. Available today from wherever you listen to podcasts.
You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you. Hello, this is Richard Jacobs with the Future Tech Health podcast, and I have Dr. David Cave. He's a gastroenterologist. He's a professor at the University of Massachusetts Medical School, teaching gastroenterology. So, Dr. Cave, thanks for coming. How you doing?
I'm well, thank you. Yeah,
tell me about in your teaching. What is gastroenterology about? Is it just about gastric bypass, or is it what kind of conditions comprise a typical gastroenterologist practice?
So for a general gastroenterologist, it's quite wide-ranging. We look at study diseases of the esophagus, the true stomach, small intestine, and colon, and include the pancreas and liver. So it's really gastroenterology and hepatology. And then people specialize in subdivisions of that.
And what got you personally interested in this area, versus others?
Well, I've had a number of interests over the years, but the most current one is a interest in what's called video capsule endoscopy. These are little pills that you can swallow. They're quite large in the sense that they're bigger than the average aspirin, but nevertheless they're pretty easily swallowed by most people. And these have the capability of taking pictures all the way through the GI tract. And it's given us a new way of looking at the intestine, providing very useful diagnostic information. They're not able to do anything at the moment. They can't biopsy or anything like that, but they can give us information in a way that nothing else can.
Yeah.
And I've been using these since the day the first device was introduced back in 2001.
Oh, wow.
And the reason for that was...
I think I've seen a video of it. I think I've seen images that it looks like mostly smooth walls or sometimes wrinkled walls as you go down through the tract. But I'll ask you about what you've seen. But go ahead.
Yeah, so my interest in it really developed very early on when I was interested in bleeding from the small intestine, which at that time we used to call obscure bleeding because nobody could find the source of the bleeding. And because we had some rather, in retrospect, primitive instruments, which really couldn't get us into the small intestine, which is about 18 feet long or thereabouts. So because we couldn't get there was really no interest in the small bowel. And then I saw this little device in a focus group, and so immediately contacted the company that was producing it. And the day the FDA approved the device, I started working with it. And in the Northeast of the United States, I was the only person really using it for about a year and a half. And in that time, unleashed a treasure trove of new information, which nobody had been able to see before. It was quite extraordinary.
So what kinds of interesting things have we learned?
by having people swallow these cameras?
Well, there's the pretty well established information that you can get now in terms of bleeding from what we call angiectasia. These are superficial blood vessels, and they can produce just a mild anemia or profound blood loss. And now it can provide a map of where these are, and then we can set about looking at the best way of treating them. And we now have a whole range of different long scopes, which we call deep enteroscopes, which we can get at many of these, not all of them. Occasionally we have to resort to surgery. And then the rarer issues are tumors, either benign or malignant, inflammatory bowel disease, Crohn's disease particularly, and various genetic syndromes where you grow polyps in the small intestine, which otherwise very hard to deal with because you weren't really able to visualize them. So it's opened up a whole range of things in the small intestine, and the field is evolving, and perhaps we can talk about that later, but getting the capsule outside the small bowel to look at a variety of different things and ways of controlling it and so on.
Interesting. So what have we learned about some of these common diseases like Crohn's or IBD or bleeding in the intestines? What do we see now that we didn't see before? Do we understand the causes or the consequences of what the morphology of these diseases look like?
Yes, so we can see things now in a way we literally could not before, because conventional X-rays and barium studies really didn't reveal almost any of this. CAT scans and MRI scans are quite helpful, but they are not as don't have as high a resolution as the capsule devices. So if you're talking about bleeding, those devices are no good for looking for these little angiectasias, but we can see them very easily with these capsules. So we can then define how we treat them. And similarly with tumors, if the tumors are large, they're obviously easy to find by a variety of different techniques. But when they're small, in the order of a centimeter, they're very hard to find, but the capsule's good at picking them up. And then with Crohn's, again, you can see the basic disease quite easily, but you don't know the more subtle aspects of it, little tiny, what we call aphthoid ulcers, little tiny ulcers with a little red ring around them. Those you really can't see with anything except the capsule.
Yeah.
And then to your question about, what's it really opened up is a disease which in 2005 I knew nothing about, with an acronym of CNSU, which is chronic non-specific stenosing ulcerative enteritis, good mouthful, described really in the Far East, not in a large number of patients, but when I ran into this in Tokyo at a meeting, I came back and started looking for it, and we've now found about 25 cases. Oh. And this was entirely due to the fact the capsule is able to see this ulcerative disease in a way that no other modality can.
Have you, is there a time stamping feature? When you swallow the pill, you could look at transit times through the different parts of the digestive system and maybe get a better understanding of, transit time correlates to any conditions or anything like that?
There is a special capsule called the Smart Pill, which measures transit time and acidity in the gut. But so does the capsule that has the video capability also transits in exactly the same way, so you can make the same measurement of distance, but it doesn't measure pH, but it's not terribly useful measurement. But the capsule spends a few seconds in the esophagus under normal conditions, maybe 40 minutes in the stomach, true stomach, and then transits the small bowel in about 4 hours. And then unless you do what's called capsule colonoscopy, you don't see much, if anything, of the large intestine. But if you clean out the large intestine, then you can see the large intestine quite well.
Can you see the various sphincters? As you enter the stomach, as you leave the stomach. So what do those look like? Anything interesting there?
Sometimes. Normally, they are most useful for defining where the small intestine is, and then that gives you some idea as to where any particular lesion is. Of course, you can measure the percentage of time it takes to get to a particular point from one of those fixed points.
Any sense of the variation in transit time between different parts of the digestive system amongst different people, or Any interesting trends?
It's surprisingly variable. I've seen it go through the stomach literally in seconds, and I've seen it go through the small intestine in as short as 20 minutes, and I've seen it take us, many, many hours. Since I got started on this, the battery life's extended very considerably, and some of them now, whereas we started with 8 hours, maybe out as long as 20 hours. So it's changed a lot.
Oh, wow.
And the
has
image
this led to like a rewriting? Has this changed what's taught now in medical school? I mean, I would think the learnings have changed what we thought, and now things are taught differently.
Yes, it's certainly making an impact on that, and some of the future developments are going to change a lot of what we do. Haven't changed the way we manage acute gastrointestinal bleeding. Hasn't changed in 50 years, but this is going to change that.
How often are these pills used? Are they expensive? And is this like the first go-to for gastroenterologists, or is this only like used in very rare cases?
No, certainly not in rare cases. It's becoming, most practices use it. The big thing that's is come on really on the waiting at the door, if you like, is artificial intelligence and assistance in reading it. Because at the moment, unless you're doing it on a frequent basis, it can take you quite a while to read it. I can read one of these capsules, depending on how long it takes to transit, in 15 to 20 minutes. But somebody who only uses it, once a month is going to take probably 40 minutes or longer to read it. So that's one of the things that slowed down acceptance of the device.
Well, I could also see you'd want to have machine vision. So you don't have to have a tech sit there and watch, the same movie over and over, waiting for the moment where you see a cyst or a tumor or something. So
exactly.
If machine vision could automatically pick up, non-normal structures, then it could just buzz through the tape and see it quick,
Yes, and just present you with the findings. And I think within 5 years, the AI and machine learning will be transformative.
Yeah, that's super interesting. Huh. Have we used this on people with gastric bypass? And if so, what do you see there?
So obviously you don't see the excluded stomach, but you see the small intestine in exactly the same way as you would normally. Transit time's a bit quicker because you doesn't have to wait. And as far as I know, this device is one of the safest devices we ever use, in the sense that I think there are probably 4 million that have been used over the last from 2001 till now, maybe more, particularly now that China's jumped on. There has not been a death associated with it. There have been 1 or 2 very rare complications. So it's at least as safe as taking a blood sample.
And I guess if you have to do an intervention, the whole digestive system is pretty long. Like you said, the intestines are 18 feet long. This can pinpoint to within, I guess, an inch where the problem is. Then you can go in very specifically and fix an area if possible, right?
Well, unfortunately, we cannot localize it anywhere near that accurately at the moment.
Oh.
It's guesswork. So you can get to the nearest 2 or 3 feet is probably the closest you're going to get. But nevertheless, that's really helpful. Just because we don't have a pedometer on the device. A lot of very good people have looked for ways of measuring it, measuring how far it's gone. And I think, again, very shortly we will have a technology that will be able to pinpoint it to the nearest few inches.
Well, I mean, this may take a long time, but if you had a person standing, against a screen, and then you had a camera or some kind of device that would send a signal to and get a signal back from the pill, you literally could probably trace out on the person where the pill is at that time and, observe its path and then reconstruct exactly how their intestines and all that are shaped and where they are 3-dimensionally. I mean, I guess it would take a long time, but you could do some of that.
I mean, that's the catch, that time is money. And to have somebody do that, I mean, we've managed quite well in terms of localizing where something is. And by and large, the correlation between what a capsule sees and what is seen by the technique I mentioned a little while ago, the deep enteroscopy, is really very good. Although if you go from the top, you can go from the bottom, but there is still, in most people, a no man's land which you can't get to. But we can manage that.
What happens to the pill as it goes through the digestive system? I mean, wouldn't the camera get obscured by, the stuff in the stomach, or as the digestive chyme develops or the feces develops, it would obscure it and train the camera at some point?
Yes, that's an ever-present problem, and people use various different preps. We personally don't, particularly if we're looking for bleeding, because we don't want to disturb where the blood's coming from. And it's still very contentious whether a prep is necessary. So if you've got a simple pill that you can swallow, you only have to be fasting for 8 to 10 hours. People love that because it's such an easy test to do.
Yeah.
And then, as I say, if you're going to do the colon, then that's the prep is at least as rigorous as for colonoscopy.
Oh, why?
Well, because you haven't. There's no screen wiper on the capsule, so you've got to have really an absolutely clean colon to see polyps in the colon.
I don't know if this is ridiculous, but have you ever tried to mount a camera somehow in the wall of the colon and watch it as it goes from empty to full and see what that looks like?
Very interesting question. No is the short answer. There's a capsule which is developed or in development, which uses, I think, a form of radiation which can work in the unprepared colon and detect polyps that way. It hasn't hit the market yet, but the other problem is that the insurers don't want in general to let loose the colon capsule, because although it's a good diagnostic device, it has no therapeutic capability. So if you find a polyp, you've still got to do a colonoscopy. And a good colonoscopist is going to find polyps in about half the population. So they just don't want that in additional expenditure, which is not unreasonable.
Yeah. So you must have seen tons of these camera journeys. What are some of the interesting things that jump out at you?
So as I say, things like there's a condition called the Peutz-Jeghers syndrome, which is genetically determined, and from childhood onwards, people develop polyps, and they may have literally dozens of these throughout the small intestine. So to be able to see these, and as they evolve, you can take out the big ones, leave the little tiny ones, and then 3 years later you recheck it, and some have grown, some have not. It's it's offered us a new window on the world.
Okay.
And we're taking it now into a variety of different areas. For people who have acute bleeding, we have we did what's called a randomized controlled trial, which is the sort of gold standard quality trial. We compared the detection of active bleeding with using a capsule really as soon as the patient comes into the hospital with a standard of care. And we were almost 3 times better at detecting the bleeding. So then you can do, once you know where the bleeding is, if you need to, you can do what I call site-directed therapeutic endoscopy. So that's going to change a lot of what we do. And there was a gentleman
I said it already, but I mean, I could see that the machine vision part of it's going to be critical here in feature identification.
Actually, for that, well, yes and no. If you could provide, if the machine learning could be translated into providing, say, a sound signal or a signal to your cell phone, that would be fantastic. But to pick up blood in the intestine is actually very easy, and you can look at the capsule in 2 minutes and see where the bleeding is coming from. You may not know what's bleeding, but if there's active bleeding going on, you can find it really quickly.
Have you noticed anything? You've been doing this for, 18 years?
Yes.
Using these cameras?
Mm-hmm.
Any trends over the past 18 years? Any new things that are suddenly appearing or that you see in different populations?
Yes. So in the States, there are 4 FDA-approved devices which do really much the same thing. They use white light, and the quality of the cameras in them is quite extraordinary. You probably know what a villus is. They're little hairs on the small cells of the small intestine. You can pick those up, and those are really tiny. tenth of a millimeter. So gives you an idea of how refined the imaging is. But the thing that's probably gone as far as it's going in those sort of terms. But what needs to be explored is different wavelengths of light, see if that helps improve detection of bleeding or tumors or other things as yet undefined. But I think one of the most exciting things is a Chinese company has recently got a magnetically controlled capsule to work. And this is something you can swallow. You can get a few images of the esophagus, and then with a joystick, you can literally steer the capsule around the stomach. And this does not require sedation, so a patient can come in, have this examination, and you can take pictures with it, send those over to the doctor. The patient could go over to see the doctor and have his diagnosis made and treated, all in the same morning without having to take days out to have the sedation and then go back to see the doctor another day.
What I was thinking, I pictured like taking a magnet and putting it on someone's stomach and moving it around and having the pill like run back and forth through their intestine.
Yeah, well, it's very challenging to get it to go through the small intestine because it takes so long. But in the stomach, which is a sort of fairly large organ, it's very easy to control it. And I think that's going to become a very useful tool for an awful lot of settings.
So what does the inside of the stomach look like? Is it interesting, or is it really just boring, blah, nothing special? Like, what have you seen?
Well, again, you can see polyps, you can see ulcers, you can see tumors, you can see bleeding. Much of the time, when people complain of upper abdominal pain or reflux, there's a condition which you cannot see because it's a sensitivity issue called functional dyspepsia. It's really common. It's actually much more common than true reflux of acid, although the symptoms can be identical. And I think this capsule, this magnetically controlled capsule, will be a big help in sorting this one out.
Yeah, I wonder if you could have a capsule that you could pause its journey at any given point and look, upstream and downstream and just observe for a little while.
Yes, I think that sort of thing has been conceptualized. It hasn't been put on the market, but you're absolutely right. If you have somebody who's got really hard to find bleeding, to be able to moor a capsule somewhere in the intestine, perhaps magnetically, and wait for blood to come by, that may be very useful.
Yeah, okay. Have we had anyone that, swallowed the pill like once a month for a year and tracked, how things look different? Have we ever done something like that?
Something similar. I've had one elderly patient who had bleeding. We didn't know where it was from the small intestine. He had really bad heart disease, so to operate on him was really high risk. And we used 4 capsules in a week to identify where the bleeding was coming from. We finally had a really good idea of where it was coming from, and we took the risk of operating, found the bleeding site, removed it, and sewed him back up, and 2 years later he's doing great.
Right.
So cool. With a little persistence, compared with the cost of keeping somebody in an intensive care unit, the cost of the capsule is pretty trivial.
Yeah, that's true. I mean, do you have any estimate of what the costs are? I know, insurance, no insurance, but...
yes, I mean, the basic capsule costs about $500, which in the greater scheme of things is not that expensive. And then there's a technical fee and a professional fee.
Okay.
So it's not very different from the other endoscopic procedures.
Okay. All right. So again, any trends over the 18 years that you're seeing? Are people's digestive systems changing in reaction to our diets as our diets change over time?
You can't see that. That's really a metabolic problem, which is not, you can't visualize. Capsule has not evolved. I'm sorry, the intestine really hasn't evolved in that short time frame. But we have a much better idea of what's normal and what's not normal. And that's going to be a huge benefit to help machine learning. Okay.
What do you think will be the upcoming add-on features to these camera pills?
As I mentioned, I think it will be interesting to explore different wavelengths to see if they help us detect these little abnormal blood vessels. people have conceptualized putting, instead of visualizing chip in there, that conceivably could use ultrasound to look at things. That hasn't materialized yet. That's the problem with that, is it requires a lot of energy, and unless you can provide energy from outside, which is theoretically possible, the current battery is just not capable of providing that.
Yeah.
But I think there are going to be additional uses. I think in the emergency room, for example, seeing if what's happening in the esophagus in people who come in with chest pain, and there's certainly more people who have esophageal problems than cardiac problems in a population who presents to the ER with chest pain.
You mentioned sampling. Would you have? How would that be accomplished? How would you imagine it could be accomplished for the pill?
So what's been reported is the use of a string attached to a capsule, so that, because at the moment what we do is to lay people down on their side, and then they swallow the capsule and sip water, and it moves through the esophagus fairly slowly, but not slowly enough. But by attaching a string, it's been shown that you can adjust the position of the capsule. You can either fix it or move it up and down. So that may be a development that will happen in the not too distant future.
Well, that's right. Is the capsule tumbling as it goes through the system, or is it kind of stay in one orientation? In
the esophagus, it's in one orientation. It can do anything in the stomach, and then in the small intestine, it can tumble. We actually didn't know that until we were doing a trial for one of the manufacturers, and we got somebody to swallow one of the capsules, and then 40 minutes later to swallow a second one. And sometimes the capsules would catch each other up, and you could see the capsule in one position, and then 10 minutes later it was facing back at you.
Huh.
So we proved that it was tumbling.
Wow. Is it tumbling slowly or fast?
Fairly slowly. It's a passive device, so its movement's entirely dependent on what we call the peristalsis in the intestine, the contractions of the intestine. So it moves through like a piece of food.
Yeah, with peristalsis, does it move slowly and then fast, and slowly and fast, or does it come to a stop and then move, and stop and then move?
You're exactly right. All of the above. And in fact, that's one of the ways that up until now, the algorithms to help the reader has been able to, the algorithms can take out the same, if the image is repeated in the same place, for 5, 10, even 15 minutes, they can take all those images out because it doesn't provide any useful information. So that cuts down dramatically on the number of images that you have to review.
Why couldn't you selectively have the capsule off balance in terms of weight, make it ever so slightly weighted so that it will tend to go a certain way as it goes through the systems?
Great question. Never been done that I'm aware of, simply because I don't think people have come up with a thought as to how that might help. What has helped to some extent is having a camera on both ends. And indeed, there's one camera one capsule which has got 4 cameras, and that gives you 360-degree imaging.
Oh, wow.
So all sorts of little tricks have been developed, but they haven't got through the problem of reading, which is now about to change. So I think you're going to see.
I wonder if you could do like a mini gyroscope that would keep the camera always facing a certain direction, along with a slight weight bias.
Yeah, I mean, all of these things are possible. The question is if the incremental benefit is worth it. Because, if you're looking at acute bleeding, you can get up to picking up the bleeding site in 90% of patients if you catch it early. So you don't need additional tools. And if you don't catch it first time, if they rebleed, you can catch it second time, because then you've got a very high likelihood that you'll find where the bleeding's coming from. Yeah. So it's.
What about the treating the surface of the capsule? Like, what happens? Have you gotten the capsules after someone's expelled them and looked at the surface and see how it was maybe eaten by acid or affected, and maybe you could treat the surface and have it layered where the outer surface is going to wear away, let's say in the stomach, and then the surface inside of that would be reactive in some way to the intestine, and you get data that way.
Yeah, the capsule does have a very slippery surface, and particularly over the lens cap, so that almost nothing sticks to it. So you don't get much, although you can't remove what's in the intestine, it rarely, if ever, gets a piece of stool or something stuck on the lens. So as it moves through, it stays clean, and you can continue to image very clearly. It's remarkable. And because the capsule's quite big, it's most of them are around 11 by 26 millimeters. That's a good sized pill, but 99 out of 100 people can swallow it without too much trouble.
Yeah.
Occasionally, people can't swallow pills, and they can't swallow this one either. But it's pretty rare that people cannot swallow it. And if push comes to shove, we have ways of delivering the capsule to the small intestine by an endoscope.
Mm. Yeah, well, I've swallowed big pills and small ones, and it really depends on the shape and the smoothness and all that. And the wrong shape, doesn't matter if it's tiny, it's hard to swallow, at least for me. And the right shape, you can swallow big ones.
Yes, that's exactly right. Yeah.
Yeah, like
and for
oil
kids,
ones are huge.
We get them to. I'm not a pediatrician, but if you get them to swallow hard candy to practice, they get pretty good at it. And even a 10 or 12-year-old can do it.
Yeah. Oh, interesting. I guess there's so many things that can be done with these pill cameras. We still have yet to explore, but there's a lot that can happen.
Yes, it's opened up a whole new horizon.
How would you do sampling? Would the pill have to, I don't know.
The problem with
would the
sampling,
surface be rough to sample, or what would happen?
You could, but the problem is you've got to get it through the colon, which is going to give you immediate contamination at a high level. And unless you chase it through with a sort of vigorous prep, if you took a biopsy, it's going to deteriorate because it takes time to get through the intestine. Once you've got a piece of tissue, the sooner you can get it into fixative, the better. So if it had to wait 12 hours to get through, it could be pretty degenerative at that point. So I don't think it's going to be very convenient to do biopsies, but just simply visualizing, and maybe what we call optical biopsies with machine learning, we can get better and better at defining exactly what we're seeing.
Yeah, that's true. And does the pill tend to just run along the wall, or does it float in the middle, or does it do both? Like, what does it look like?
Yeah, it's really all of the above. As we talked about, it tumbles. It can slide along. And in fact, one of the interesting things we've noted is that if there's a big tumor, there's a significant chance of missing it because the capsule will slide along the side of it and not visualize it because the field of view isn't quite big enough to 100% visualize things that are on the side of the capsule. But I think that's another thing that will improve, I think, with time, is the field of view, which is generally around 150, 160 degrees. Eventually it's going to get widened out to 180.
Yeah. Okay. Well, very interesting. So where are you at with your work and your teaching? Like, is there anything new that's coming that you're focused on? Are you doing any research, or you're just keeping abreast of what's happening clinically and reporting on that in your teaching?
Yeah, so I do a lot of clinical research. And in fact, our next project, which we're just about to start, is to expand on what we've seen and a group in Hong Kong has seen, so that we now plan to take people straight from the emergency room into what's called a clinical decision unit and keep them there for up to 24 hours. As soon as they get there, then you drop a capsule if they're bleeding or randomize them to standard of care. And we're going to compare, again, how quickly we can find the bleeding, where it is, and then make management decisions as to whether the patients need to be admitted or go home. And again, if they randomize to the capsule, they love it because it's much more comfortable than having scopes put into various orifices. And certainly some of them who stop bleeding can be very safely sent home because nobody likes coming into hospital, and then scoped as an outpatient. So I think we're on the cusp of doing things that are very different from what had been done previously.
Yeah. Have you ever swallowed one of these pills and watched your own intestinal movie?
Actually, I have not, but I've had many of my colleagues swallow them in various trials. There was a piece of physiology that got done many years ago, because we didn't know how the capsule behaved in terms of compared with other food particles. And somebody swallowed the capsule and at the same time swallowed a little blue bead about 3 millimeters or smaller in size. And much to everybody's amazement, the two traveled together, which, all the previous data suggested that shouldn't happen.
Yeah.
So that was a cute little experiment. We didn't pursue it systematically, but we learned from that.
So what's the range of time that it'll take someone, from the time they eat something to the time they, expel it on ballpark? I mean, what's the range of time?
Range, I mean, if you've got a diarrheal state, something can go through in an hour or two or less. Or it may take many days. If somebody's constipated, they may have something get expelled, a week or even 2 weeks later. So it's a tremendous.
What if you're not constipated?
If you're not, then the transit time is usually 24 to 48 hours.
Oh, that long? Okay.
Yeah.
Interesting. Well, very good. So, what's the best way for listeners to find out more? Maybe get in touch or ask questions, or just I don't know if there are any videos on the internet where you can watch this happening. I'm sure that you can't see the person's face or name or anything, so you don't need to redact any info. But
correct.
Are there videos out there that people could watch? Or
there should be lots of it. I'm sure YouTube's got a lot of these.
Yeah. All right. Any way for people to again follow up and ask questions? Should they just go to the hospital website, or how should they get in touch?
If they want or need this done, they can always call the hospital, and we can oblige. Mm-hmm. Taking individual phone calls tends to get overwhelming, so we tend to avoid that if we can. It's just
right.
The workload is already so heavy that it's additional just curiosity phone calls we cannot deal with.
I understand. Yeah. So the intellectually curious, I mean, the recommended resources.
Yeah, I mean, if you're intellectually curious, you can find out an enormous amount. You just go Google video capsules, and you can find what each manufacturer has. Go to many of the individual publications about it in detail. I mean, the web is now just astonishing what it can provide in terms of information.
All right, very good. Well, David, thank you for coming on. I really appreciate your time.
You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you.